I'm Dr. Koratala from Medical College of Wisconsin, USA. It's a pleasure to be here as a part of Nephro Critical Care Review 2023. In this lecture, I'm going to provide a brief overview of VExUS or venous excess ultrasound for the nephrologist and nephro intensivist. I have nothing to disclose. When assessing a patient's hemodynamics at the bedside, we must evaluate the whole hemodynamic circuit and not over-rely on isolated pieces of information. For example, we want to know what is the forward flow, like how is the cardiac output, is the cardiac output adequate to perfuse the organs. At the same time, we must pay attention to the backward pressures of the heart. For example, if the left atrial pressure is elevated, it manifests in the form of increased extravascular lung water. If the right atrial pressure is elevated, it manifests in the form of venous congestion. So venous congestion is a consequence of elevated right atrial pressure. And why do we care about venous congestion? Because the organ perfusion pressure is dependent on both inflow pressure and outflow pressure. It's a difference between these two pressures. For example, in the context of kidney, it's a difference between mean arterial pressure and central venous pressure or right atrial pressure, or intra-abdominal pressure if it's elevated. So even if the forward flow is well preserved, if the organ afterload or outflow pressure, that is the right atrial pressure, is elevated, renal perfusion drops and results in acute kidney injury. That's called congestive kidney injury, which is a less recognized phenomena as compared to kidney injury because of volume depletion. So what is VExUS or venous excess ultrasound? It involves assessment of venous congestion by identifying the flow alterations in the veins at the organ level. It involves inferior vena cava ultrasound, hepatic vein Doppler, portal vein Doppler, and intravenous venous Doppler to assess these flow alterations. So where does this VExUS come from? It comes from this study in cardiac surgery patients in Canada, where they showed if these patients had a dilated inferior vena cava of more than or equal to 2 centimeters, demonstration of severe flow abnormality in at least two of the previously mentioned veins, that is hepatic, portal, and intrarenal, was associated with development of subsequent acute kidney injury with a hazard ratio of 3.69. And you may ask, like, we know like venous congestion is bad, like elevated right atrial pressure itself is bad. So what does doing this Doppler study add? So they compared a central venous pressure of more than 12 millimeters mercury with the severe grade VExUS, that is the Doppler demonstration of flow alterations, and the post-test probability of having AKI with a positive test was substantially higher when they used VExUS grading as opposed to central venous pressure alone. So it offers better diagnostic accuracy in detecting venous congestion and subsequent organ injury. And IVC is the first step. So if the IVC is plethoric, as you know, especially in a spontaneously breathing patient, it indicates elevated right atrial pressure. If the IVC is small and collapses well with inspiration in a spontaneously breathing patient, the right atrial pressure is low or normal. And in mechanically ventilated patients, it's not a great tool to assess right atrial pressure. But still, if the IVC is like completely like small and collapsible in a mechanically ventilated patient, it still indicates low right atrial pressure. And so if the right atrial pressure is high, first it dilates the inferior vena cava, and then the venous flow changes occur, and that's where the Doppler ultrasound is going to help us. So let's see the individual components one by one. First, let's see hepatic vein Doppler. In hepatic veins, we have inferior vena cava here, and we have three hepatic veins. One is the right hepatic vein, middle hepatic vein, and left hepatic vein. Usually left and middle hepatic veins form a single trunk to join the inferior vena cava. So from this you can note that like you can access the hepatic veins from subxiphoid window or the lateral window. In real life, accessing hepatic veins through lateral window is much easier and gives better Doppler waveforms. So this is how the sonographic anatomy looks like. So when imaging from right upper quadrant, you have the probe orientation marker towards patient's head, and the beam is first coming in contact with the hepatic vein, followed by inferior vena cava, followed by aorta. So on sonographic image, this is towards patient's head because it's a screen indicator corresponding to probe orientation marker, and you have hepatic vein here, IVC here, and aorta here. So this is the label. And you can also access hepatic vein from the traditional subxiphoid window where it joins the inferior vena cava. Usually it's a middle hepatic vein here that's seen in this window. But in general, the Doppler waveform is much crispier when you do it from the right lateral aspect. And you can also use subxiphoid transverse view to see all these three hepatic veins. Like say, for example, if you're slicing it here, you can see the three hepatic veins. So this is the right hepatic vein, this is the middle hepatic vein, and here is the left hepatic vein. This is the inferior vena cava. Excuse me. So the goal is to find a longer segment of the hepatic vein so that you are able to get the waveform even if the patient is not able to control the respiration. Or if you are doing this in outpatient setting, you can ask the patient to hold their breath in expiration and you should get a good image. And how does a hepatic vein waveform look like? Hepatic vein waveform consists of several individual waves, A, S, V, and D. First of all, on color Doppler, how does hepatic vein appear? On color Doppler, you are imaging from the right lateral aspect. So the blood is flowing away from the transducer into the inferior vena cava. So in normal state, hepatic vein must be blue. Similarly, on spectral Doppler, when you have this baseline, above the baseline corresponds to red on color Doppler, which means flow towards the transducer. Below the baseline flow corresponds to blue on color Doppler, which means the flow is away from the transducer. Because on color Doppler, hepatic vein is mostly blue, that is, flow is away from the transducer. You can expect that most of the flow is below the baseline. And if you start to see more flow above the baseline, it's getting abnormal. So let's take a look at these individual waveforms. So how does the systolic wave or S wave occur? So during systole, the right ventricle longitudinal movement is making more room in the right atrium here. As the right ventricle moves towards the apex, there is more space in the right atrium to be filled with blood, or more space to accommodate the venous return. That manifests as a nice forward flow, that is the systolic wave. So on the sonographic image, this is the systolic wave. And towards the end of the systole, this right ventricle starts to come back here. So previously it moved towards the apex. Now it starts to come back, raising the pressure in the right atrium. So your S wave will start to come down. And this wave here at the end of the S wave is called the V wave. V wave is a transitional wave between the systole and the diastole. And the V wave can be above the baseline, like a little blub above the baseline as shown here. Or it could just remain below the baseline as shown in this image. Both are normal. And during diastole, as the tricuspid valve opens here, the blood is going from right atrium to the right ventricle, and now there is more space in the right atrium to accommodate further venous return. So that manifests in the form of another nice forward wave or below the baseline wave, that is the D wave or the diastolic wave. Normally, in a patient with normal right atrial pressure, the systolic wave is bigger in amplitude than the diastolic wave. That's a normal configuration. And towards the end of the diastole, when the atrium is contracting to expel rest of the blood, the right atrial pressure increases, and that manifests in the form of a small blub here above the baseline. That is the A wave. So A wave is here. So A wave is because of the atrial contraction. S wave occurs during ventricular systole. In the middle, you have a transitional wave, the V wave, and during diastole, you have the D wave. And this is very similar to central venous pressure waveform. So hepatic S wave or the systolic wave corresponds to the X descent of the central venous pressure waveform, and the D wave corresponds to Y descent. And when you have EKG, the A wave follows the P wave of EKG. And the S wave follows the R wave of EKG, and D wave follows the T wave of EKG. So that's how you identify systole and diastole properly, because without EKG it can be very confusing. We'll see a couple of slides showing why having simultaneous EKG is very important. So what happens to hepatic venous waveform with increasing right atrial pressure? And we said normally the systolic wave is bigger than the diastolic wave, right? And as the right atrial pressure increases, the gradient between the venous return and the right atrium reduces. So there is more resistance to the systolic wave. You can imagine that better if you think about tricuspid regurgitation. And mostly fluid overload is associated with some degree of functional tricuspid regurgitation. And so what happens during this regurg? during systole, when the tricuspid valve normally closes because of the regurgitation, there is more blood going back into the right atrium, and that's offering resistance to the systolic wave. The systolic wave then becomes smaller in amplitude compared to the diastolic wave, altering the normal configuration. So in this example here, the systolic wave is smaller than the D wave. You can easily identify the waves because here is the QRS complex of EKG. So the wave that is following the QRS complex must be systolic wave. And with further elevations in right atrial pressure, the systolic wave goes and sits above the baseline. So here you can see the reversed systolic wave. Here you have the A wave, here you have systolic wave, in the middle you have the V wave. You can call this depression as V wave. And here you have the D wave. So D wave is the only forward flow or only venous return wave remaining below the baseline. And as the right atrial pressure increases further, you have diastolic wave below the baseline, but all the above the baseline waveforms fuse like A, V, and S just to form one single waveform here. You can just call that a systolic reversal. And you have one wave above the baseline, one wave below the baseline, like a to and fro pattern. That signifies very severe congestion. And generally, if you see like one wave below the baseline, it's most likely D wave. But in rare circumstances, such as severe pulmonary hypertension or pericardial tamponade, you can see D wave reversal or a disappearance of D wave. Say, for example, in tamponade, the ventricle is collapsing during diastole, right? So it cannot accommodate more venous return, so the D wave is going to diminish. But usually, if you see only one wave below the baseline, that's most likely D wave, especially if you don't have EKG. And that brings us to the point about EKG. It's very, very important that we utilize EKG if available. Sometimes it's not available, we can't do anything. But if we do have it available, use it. And it's very quick and easy. It takes about 30 seconds to stick the limb leads. You put one lead on right hand, one on left hand, and one on the right leg, and you're good to go. So, like, why is it important? So here we are showing you a waveform which appears like very classic, right? It appears like a very normal waveform that I previously showed while explaining the individual waveforms. And you can say this blub here is the A wave, here is the S wave, V wave in the middle, and D wave. Very nice. But when I put the EKG, what happens? So here is the EKG. This is the QRS complex. So the wave following the QRS complex is this one. So this must be systolic wave and not diastolic wave. And this blub here is the V wave. And this wave here is the D wave. So it's a S less than D pattern and not S more than D or normal pattern. So it's basically abnormal pattern. There are more examples. So let's look at this slide here containing of 4 different waveforms, and without EKG how we label them, and with EKG how does that change. In the first waveform here, so there are like 2 above the baseline, 2 below the baseline waveforms. I can label this one as a systolic wave, diastolic wave. I can say systole is more than diastole, so it's normal waveform. In the second waveform here, I feel like there is one above the baseline, one below the baseline waveform. Maybe it's a to and fro pattern signifying severe venous congestion. And on the third waveform here, so it appears like a wave, and I don't know what this wave is like that's following that. And you have like 2 waves like S and D. Maybe it's S less than D or whatever, but I don't know that what this extra wave is here. It's a strange thing because we are normally expecting to see only 2 waves below the baseline. And here we have on the 4th waveform, it feels like I'm seeing 2 waves in each cardiac cycle. So more or less it looks normal, like a S slightly more than D. And this patient had atrial fibrillation also. And that's why probably the spacing is slightly different between the cardiac cycles. So that's what I would think without EKG. But with EKG, how does this change? On the first waveform here, this is the QRS complex, and the wave that is following the QRS complex is the S wave. Now the interpretation changed to S less than D or venous congestion present. And here in the second waveform is very interesting. It was obtained from a heart failure patient who got cardiac transplant and following in the nephrology clinic. So heart transplant patients typically have hyperdynamic hearts. And during hyperdynamic hearts, the D and S waves fuse. So here is the QRS complex, and the waveform here is starting here. and ending here. So it's lasting over one cardiac cycle. It's a fusion wave, and it's not abnormal for this patient. So the above the baseline waveform is V wave and not S reversal. And the third waveform here, the extra wave, is because of prolonged PR interval here. So this is the QRS complex here. So this waveform that is following, that is the S wave. This is the V wave, and this is the D wave. So S more than D is normal. But this extra wave here is called atrial reversal wave because of the prolonged PR interval. So here is the P wave, and this interval is prolonged. So it has more time to accommodate more venous return into the heart. And the last one here is a patient with atrial fibrillation, like I said, but as you can see, there is only one wave in each cardiac cycle. So you can see cardiac QRS complexes here, but there is only one wave in each cardiac cycle. And remember, we said like it's mostly D wave, right? And obviously there is no wave immediately following the QRS complex here. So S wave either disappeared or there is a little bit of reversal of S wave. But the point is there is only one wave below the baseline, that is D wave, signifying severe congestion. So you previously interpreted that as S more than D or normal waveform, and now suddenly we are saying it is severe congestion. So it can significantly differ. So that brings us to the next component of VExUS, that is portal vein Doppler. Portal vein Doppler, so where is the portal vein? Portal vein is carrying blood from the gut. So it's formed by the fusion of splenic vein and superior mesenteric vein, and this thing here is the portal vein. So like hepatic vein, you can access portal vein from the subxiphoid window or more easily from the lateral window. From lateral window, if you observe this, you have hepatic vein here, right? And the portal vein is here. So portal vein is slightly anterior to the hepatic vein. Once you find the hepatic vein, if you fan the transducer slightly anteriorly, you should easily find the portal vein. And like I said, like if you fan anteriorly, you see portal vein. If you fan posteriorly, you find the hepatic vein. So in this image here, this is the hepatic vein, and this thing here is a portal vein. It goes into the liver and divides into two branches. And this is another still image here. So portal vein, it's dividing into two branches. Portal vein normally is red on color Doppler because the blood flow is towards the transducer, right? It's carrying blood from the intestines into the liver. So here we have the transducer or origin of the ultrasound beam. So it's red on color Doppler. That means on spectral Doppler, it must be above the baseline. And normally the portal vein venous waveform is continuous in nature, and it shows only mild undulations corresponding to A wave on of the EKG. And portal vein waveform is continuous and does not show these typical A, S, V, and D waveforms because it's separated from the main venous circulation by hepatic sinusoids, right? So hepatic sinusoids act as resistance sites so that whole of the central venous pressure is not transmitted to the portal vein. And it has been studied a long time ago, and the percentage of CVP transmitted to sinusoids is only about, say, 70% or 75%, even when the central venous pressure is as high as 14 millimeters mercury. And what happens to portal venous Doppler waveform with increasing right atrial pressure? The waveform becomes more and more pulsatile with increasing right atrial pressure. And further increases in right atrial pressure will lead to this to and fro pattern where you can see this below the baseline flow or flow reversal. And abnormal portal vein Doppler without elevated right atrial pressure can be seen in two important scenarios. One is liver cirrhosis, where portal vein is reflecting the local changes and arteriovenous malformations rather than reflecting the right atrial pressure. So at baseline, the portal vein can be hazy and a little bit pulsatile even without elevated right atrial pressure. And in otherwise healthy young people, it can be pulsatile too. So it has to be interpreted in the right clinical context. And here is a nice example showing like blue portal vein. Blue portal vein means the flow has completely reversed, right? And it's seen in patients with cirrhosis. This patient has cirrhosis. You can note a little bit of ascites here. On spectral Doppler, it's completely reverse flow. And this patient got a liver transplant, and on follow-up examination, you can see that it has completely normalized. And these waveforms are so dynamic. In nephrology practice, especially, or even in critical care, it's not just about the diagnosis of venous congestion. We are also concerned about what is happening to the venous congestion with your decongestive therapy, and these hepatic portal and intrarenal waveforms. All of these things change with therapy, that gives you objective way of assessing if the patient is improving or not. For example, here we have a patient with positive fluid balance of 12 liters. And the patient did not have much pedal edema. The patient was in ICU for several weeks already, has muscle wasting and all that, has some sacral edema. It's very difficult to assess sacral edema. But anyways, like when you do the portal vein Doppler, the patient had a plethoric IVC and this very pulsatile portal venous Doppler. So this patient was placed on continuous renal replacement therapy, and you can see how the waveforms transition. So compared to that previous exam, we removed about 4 liters and the pulsatility has significantly improved. And we removed further fluid, about 4 more liters, and it has become almost normal. And unfortunately, the patient got like 800 cc of extra fluid for some reason, and it became pulsatile again. We removed 5 liters here again from the previous examination. The portal vein has normalized. And the patient was taken to OR for some reason and got 4 liters of fluid, and the portal vein has become pulsatile. And after that, we removed fluid again, and portal vein has normalized. So the intent of this example is to show how dynamic these waveforms are. And the last waveform is intrarenal venous Doppler. And kidney ultrasound is relatively easy to perform, but the Doppler might not be, because the patient is breathing and the kidney is moving up and down. So you might not be able to localize the Doppler gate on a particular vessel of interest if the patient is not able to control the breath. So where do you perform intrarenal venous Doppler? So you have main renal vein, you have these segmental vessels outside of kidney parenchyma, but we are more interested to know how is the kidney parenchyma handling the congestion. So you want to image these vessels here, which are in line with the Doppler wave, or the ultrasound beam, which is the ideal place to Doppler. So you scan these interlobar veins, and interlobar veins and arteries, they're very close to each other, they are very tiny. So most of the time you get like arterial waveform on the top, you have systole, diastole, systole, and diastole. And below the baseline you have this venous waveform, because here is the ultrasound transducer. Arterial flow is going towards the transducer and the venous flow is away from the transducer. This simultaneous arterial waveform works like a built-in EKG when interpreting the intrarenal venous waveform. Unlike hepatic venous waveform, you know what is systole and what is diastole just by following the arterial waveform here. So what happens to intrarenal venous waveform, which is normally continuous with increasing right atrial pressure? It's like portal vein, right? Portal vein just below the baseline. And similar to portal vein, the intrarenal vein becomes more and more pulsatile with increasing right atrial pressure. Ultimately, you see two distinct waves, one in systole, one in diastole. That's called biphasic pattern. And ultimately, the S wave reverses. Here you are not seeing the reversal wave because it's embedded in the systolic wave of the artery, but you see only one wave below the baseline, that is the D wave. Like hepatic vein, if you see only one wave below the baseline, it's usually diastolic wave. But usually you don't have much problem identifying what wave is what, because you have your simultaneous built-in EKG, that is the arterial waveform. And one big caveat of intrarenal venous waveforms is that these waveforms are not well validated in chronic kidney disease. For example, I got this image from a chronic kidney disease stage 5 patient who is not on dialysis from nephrology clinic. The IVC is not dilated. There are no other stigmata of venous congestion, but here you can clearly see that there is a biphasic pattern suggestive of congestion. So it has to be interpreted in the right clinical context, like any other sonographic parameter. So how does the VExUS grading look like? When you put all these things together, how does it look like? For the purpose of grading, we can categorize each waveform into normal, mildly abnormal, and severely abnormal. Hepatic is normal if S is more than D. S less than D is mildly abnormal. S reversal is severely abnormal. Portal vein less than 30% pulsatility is normal. So it's usually more or less continuous. But in the same cardiac cycle, if you go to the highest point and lowest point and see by how much the velocity is differing, that gives you the pulsatility fraction or percentage change in the pulsatility. So normal pulsatility is less than 30%. 30 to 50% is mildly abnormal, and more than 50% pulsatility with or without flow reversal is severely abnormal. Normal intrarenal venous waveform is continuous. When you see this biphasic pattern with two distinct venous waveforms, that is systolic and diastolic waveforms, that's mildly abnormal. And if you see only the D wave or the diastolic wave below the baseline, that's severely abnormal. You call it grade 0 or no congestion when the IVC is small and collapsible. In this study, the IVC less than 2 centimeters was considered small. You have to take it with a pinch of salt. Say if you are dealing with a small body surface area patient, an Asian patient might have smaller IVCs at baseline compared to Western patients. So the point is, if you see a plethoric inferior vena cava without much respiratory changes, it appears round on short axis, then think about high right atrial pressure, and you can still perform VExUS even if, say, IVC is 1.9 centimeters. And grade 1 is mild congestion, where you have a big IVC, but any combination of normal or mildly abnormal waveforms. So you have any of these waveforms here, normal or mildly abnormal. That means you don't have any severely abnormal waveform. And you call grade 2 or moderate congestion when the IVC is big, and you see at least one severely abnormal waveform. So out of these three here, if you have at least one of these patterns, then you call it grade 2. And if you have at least two of the severely abnormal waveforms, you call it grade 3 congestion or severe congestion. And this is the pattern that correlated the most with acute kidney injury in the original study. And let me tell you that this study is new, but the individual waveforms have been studied before the concept of VExUS came in. So the portal vein has been studied before, hepatic vein has been studied before, and intrarenal vein, there is a lot of data in heart failure patients, the prognostic implications. And here is another nice example showing how the congestive nephropathy improved in combination with these waveforms. Initially, the patient had a creatinine of 2.6 milligram per deciliter. All the waveforms are severely abnormal. Hepatic vein D only pattern here. Portal vein 100% pulsatile with flow reversal. Intrarenal with only D wave below the baseline. Here you don't have arterial waveform, that's why you're seeing the S reversal. If there was arterial waveform, it would look like this. So here, this thing here is the S reversal of venous waveform. And with the diuretic therapy, the creatinine improved, but the waveforms remained abnormal. So we said continue IV diuretics. And after that, the creatinine improved to 1.7 milligram per deciliter, and the portal vein has almost normalized. Hepatic vein also got much better, though S remained slightly less than the D wave. It's very mildly abnormal. Intrarenal vein also improved. Now you see biphasic pattern instead of monophasic. And with creatinine going to baseline of that patient had CKD. The portal vein remained normal. Hepatic vein was completely normalized. Renal, it still is biphasic, but usually intrarenal venous waveform takes slightly longer because of the interstitial edema to improve. So you can see that the congestive nephropathy improves, and there is simultaneous improvement in the venous waveforms. This is how we use these waveforms in real life. And VExUS does not discriminate between volume and pressure overload. So if you have a VExUS grade 3, it does not mean it's all fluid overload. You can have a patient with chronic severe pulmonary hypertension and have VExUS grade 3 at baseline. But usually in such patients, we can still normalize portal vein or at least like reduce the pulsatility of portal vein with the decongestive therapy. Again, you have to interpret everything in the right clinical context. And you can use other veins. For example, you can use femoral vein Doppler to gauge the right atrial pressure. So normal femoral vein waveform looks like this, nice respiratory variations and relatively continuous. With increasing right atrial pressure, it becomes pulsatile like that of portal vein. This image I obtained from a patient with severe heart failure. You can see this to and fro pattern of portal vein, and on the color also you can see that normally it must be blue. Here you see like one blue, one red, one blue, one red, like a police siren. That itself is a bad sign, meaning that itself should warn you that something is abnormal. And how about this femoral vein? Is this suggestive of high right atrial pressure? Is this pulsatile? No, it's always good to have a simultaneous EKG, right? So when I have EKG here, this is not all one cardiac cycle here. So this is encompassing like 3 cardiac cycles. So this is not because of congestion, but actually this image was obtained from a patient with cirrhosis and very small IVC that is collapsing due to hyperdynamic circulation. And whenever the IVC collapses, you see these gaps here. And when it's opening, there is more blood suddenly going there. That's why it gives you like a peak and depression kind of waveform. So having EKG always helps. You can and also like femoral vein waveform is a little bit less sensitive for right atrial pressure because it's farther from the heart, right? Here is the right atrium with high pressure. So hepatic veins and portal veins are much closer, like intrarenal vein also closer to the heart compared to femoral vein, which is somewhere here. So it's less sensitive, though it's a little bit more specific for right atrial pressure. And you can also use internal jugular venous waveform, which is very similar to that of hepatic vein waveform. When other waves are not trustworthy, for example, in cirrhosis, you can always use more veins. So all these veins have been studied individually. This is called extended VExUS or VExUS. We proposed to include all these veins in addition to the traditional hepatic, portal, and intrarenal veins. You can do internal jugular Doppler. You can do superior vena cava Doppler, either from the suprasternal window or subxiphoid bicaval view. You can do splenic vein Doppler, and you can do femoral vein Doppler. No matter what you do, don't forget to interpret these in the right clinical context. So thank you so much, and happy to take any questions.